much for the introduction, Professor, and thank you very much for joining us to this session. My talk is going to be quite interactive, so I present 3 cases where we are going to use the different imaging techniques and how we use it and what the guidelines say. So it's a little bit of mix, but I expect that you interact with me and raise your voice. So these are my disclosures. So the first case that I present to you is this 35-year-old female without cardiovascular risk factors. She explains chest pain on exertion, climbing stairs, or carrying heavy things since months, and it is described as a pressure on the chest radiating to the neck and shoulders and internal part of the left arm, and she needs to stop to relieve it, and it takes 15 minutes to disappear. On the physical examination, you can see that the heart rate is 75 beats per minute, normal blood pressure, no murmurs, and in the lab, the total cholesterol is 3.6, HDL of 1.7, and LDL of 1.56. And this is the EKG. We can see that there is sinus rhythm, but it's quite abnormal, with signs of hypertrophy and a very pronounced negative T waves in the anterior wall mainly. So this is the patient that comes to our outpatient clinic. And what do the guidelines say? The guidelines of this year on the chronic coronary syndromes. So basically, when we approach a patient with angina or dyspnea and suspected coronary artery disease, we always assess the symptoms and perform the clinical investigation. If we think that it's unstable angina, then we follow the acute coronary syndrome guidelines. We need to consider the comorbidities and the quality of life. In this case, one of our patient doesn't have any other comorbidities, and we check any of these examinations if it's performed. Resting EKG, I think that is primordial, the biochemistry, and the echocardiography at rest. And if the ejection fraction is below 50%, then we need to go to the next section. So I present to you here the echocardiogram. This is the apical 4-chamber view. This is the apical 2-chamber view. This is the echo that we can do. It's one of our cases, so the image quality sometimes it can be questionable, but this is one of our cases. So here it comes the first question to you. What would be your diagnosis in the clinical management? Who votes for the first one? This is a myocardial ischemia in the LAD region, and I will refer the patient for invasive coronary angiography. Anyone for this one? Okay. The second one, I don't know. I do not see well the endocardium with the echo, and I would recommend a contrast transthoracic echocardiography. Who goes for this one? No one? And the third, this patient explains atypical chest pain, and I will ask for an exercise EKG. Is anyone in favor of this one? And the fourth, this is typical chest pain with abnormal EKG. I will request a functional imaging test, stress echocardiography, or myocardial perfusion test. So this is the majority. Okay. So actually what we did, we don't see really the endocardium of this patient. That image quality should not be considered optimal to assess the function or not. And there are contrast imaging techniques that can help us to see that actually this patient, what it has is an apical hypertrophy. And this is why there are also so abnormal EKG. So what to do in a hypertrophic cardiomyopathy? That's a little bit difficult in order to assess ischemia. So the next question will be, does this finding exclude the coronary artery disease? So who votes for the first one? Yes, 100%. The cause of the chest pain is apical hypertrophic cardiomyopathy, and we don't need to do anything else. Anyone for this one? No. The second one, no. I would do an anatomical imaging test to rule out or to rule in coronary artery disease, and for example, I will use a coronary CT angiography. Okay. No, I would do a functional imaging test to rule out or rule in coronary artery disease, and I will ask a SPECT. Anyone for this one? Much less than before. And the fourth, depending on the pretest probability, I would refer the patient for additional testing. So far we have not assessed the pretest probability. And this is one of the steps that the current guidelines recommend. So after we have done the resting EKG, the biochemistry and the echocardiography at rest, and the patient has a normal ejection fraction, we need to assess the pretest probability and the clinical likelihood of coronary artery disease. Is the cause of this chest pain a coronary artery disease? So this is the table that has been modified from the last guidelines to assess the pretest probability of coronary artery disease. We have still the categories of chest pain, typical, atypical, and non-anginal, but you see that the guidelines have also included dyspnea. In this case, the patient was quite young, the age between 30 and 39, and is a female, is typically a 5% risk. So it's rather low. And what do the guidelines recommend in patients with a low likelihood of obstructive coronary artery disease? So this is one of the schema that you can have also in the guidelines. Here you see the clinical likelihood of obstructive coronary artery disease from very low to very high. And here you see the diagnostic imaging techniques that we can choose, always based on the clinical likelihood of the patient characteristics and preference, the availability in your center, and also the local expertise. These need to be taken into account. So if the patient has a very low likelihood of obstructive coronary artery disease, what is recommended here is an anatomical test using a coronary CT angiography. But if the patient has a much higher risk of obstructive coronary artery disease, what the guidelines recommend is evaluating ischemia. That will be the preferred imaging test. And when it's very high risk, that is clear an acute coronary syndrome, in that case you use an invasive angiography. And here there is the algorithm. Which are the factors that are going to put a patient into low risk or high risk? So here we have, if we consider starting with a coronary CT angiography, we need to consider that test when we have a low clinical likelihood, patient characteristics that suggest that we will have a high image quality. For example, patients with atrial fibrillation, patients that have a high heart rate. These are patients that are going to be difficult to image with CT coronary angiography. We need to be sure that the heart rate is regular and the heart rate is around 60 beats per minute. That is where we have the highest image quality. We need to take into account the local expertise and availability, whether we want information on atherosclerosis or not, and if the patient doesn't have previous history of coronary artery disease, so this would be one of the factors that will make us choose for coronary CT angiography. And in this case, the patient had a low clinical likelihood, so actually what we did is to perform a CT coronary angiography. For the ones that initially asked for a SPECT and they remain using SPECT in these patients, you have to be aware that patients that have an hypertrophic cardiomyopathy, apical hypertrophic cardiomyopathy, they may show abnormalities on SPECT. And actually, if you take the bullseye plot, you see this sort of sun imaging with a defect of hypercap uptake in the apex, and that can give us an erroneous information for the basal segment. So that would not be the imaging technique to use in patients with an apical hypertrophic cardiomyopathy. And if we go to the next one. So what we did was a CT coronary angiography, and you can see that this patient has completely normal coronary arteries. So then this patient, we could rule out that she doesn't have coronary artery disease. We can refer her for the general practitioner. And CT is a very powerful technique because I'm going to highlight this only trial. There have been several trials on the use of CT coronary angiography to evaluate patients with suspected coronary artery disease. One of the largest registries is the CONFIRM trial, but the Scott Hart trial has the peculiarity that these were patients with a stable coronary artery disease who were randomized to a standard of care, and standard of care meant to do optimal medical therapy and perform exercise tests, or patients who were undergoing standard care plus CT coronary angiography. And you can see that over the years, at 5 years of follow-up, the patients who were referred for CT coronary angiography, they have a much lower event rates of non-fatal myocardial infarction or death for coronary heart disease than the patients who were referred for standard care alone. And this was different for both endpoints, but also for non-fatal myocardial infarction. One of the reasons that it was criticized to this trial is that actually if you refer the patient for CT coronary angiography, they usually are more frequently also referred for invasive coronary angiography because you have more frequently coronary artery stenosis or calcification that you cannot assess the severity of the coronary artery atherosclerosis. But actually that was not true because at 5 years of follow-up, you can see that both groups, both curves, converge at the same area. So CT coronary angiography, Scott Hart trial, shown that it's not associated with a higher referral for invasive coronary angiography. And the most important thing is that what you can see here, that the patients who were referred for CT coronary angiography, they were more frequently adhering to the medical therapy. So they were much more frequently under statins than the patients who were not referred for CT coronary angiography, which indicates to you that patients that have the suspicion of coronary artery disease, if they are referred for CT coronary angiography, they can see themselves the atherosclerosis, they can understand better sometimes the problem that is causing the symptoms, and they try to adhere much more to the medication, which is one of the important factors. So for this patient that was a low-risk patient, we performed a CT coronary angiography and gave us the solution for it. We changed to another case. This one is a little bit different. This is a 61-year-old male with family history of coronary artery disease in individuals younger than 65-year-old with hypercholesterolemia, and since 2 months explains as well typical chest pain, particularly when playing tennis. The pain spreads to the left arm and he needs to stop for 20 minutes, and after pain relief he can continue but at a lower pace. Physical examination unremarkable, normal blood pressure, normal heart rate and not murmurs, and in the lab, as the history of hypercholesterolemia shows, hypercholesterolemia with an LDL of 3.1. This is the EKG, so you see that it's sinus rhythm, quite normal, narrow QRS, no signs of hypertrophy, and no ST segment abnormalities. This is the echocardiogram. You can see the 2 and the 4 chamber view. This is a normal systolic function, no wall motion abnormalities. And the question is, which test would you indicate to diagnose or to rule out the presence of coronary artery disease? Who goes for the initial test to perform an exercise test? Some. Who performed a CT coronary angiography? Who performs a rest stress SPECT or stress echo or stress CMR, so that is ischemia test? And who performs directly an invasive coronary angiography? Some of them. Okay. So in this case, we go through the same algorithm that the guidelines recommend. This is a man with age 61 with typical angina, rather high probability of having coronary artery disease. And if we follow here, we are much more in this area where they indicate or recommend to perform a test to rule out the presence of ischemia, to see the ischemia. And this will come through this one, preferentially consider when there is a high likelihood of coronary artery disease, when you think that the revascularization is going to be likely, and again, based on the expertise and availability of the center, and if there is viability needed. In this case, there was not that. And we perform a stress CMR. This one is the short axis of the apex, mid-ventricle, and the base at rest and during stress. And you can see that here in the inferior wall, it is an area that is darker, subendocardial. This rim is the ischemia, and I can pause for you the images where you can see the perfusion defect clearly, right? And this is the result of the coronary angiography. The left coronary artery has some atherosclerosis but no significant lesions, and the right coronary artery has a significant lesion proximal, another one before the crux. So in this case, the patient were referred for invasive coronary angiography and treatment. So in this case, also the CMR gave us the solution. And finally, the third case, this is a 68-year-old woman with type 2 diabetes, hypercholesterolemia, has peripheral artery disease as well with claudication at 500 meters, and presents chest discomfort since 2 months with a typical chest pain and dyspnea. This is the EKG. It's a sinus rhythm with negative T waves here in the inferior wall. And this is the echocardiogram. This is a 4-chamber, 2-chamber, and 3-chamber view. The apex is difficult to see, but in general, I would say that there are no major wall motion abnormalities, and the function is normal. We go again to the same exercise. This is a woman, has typical chest pain, but again, it comes into the category of high risk or high probability of having coronary artery disease. So the question again, which additional test would you request to diagnose coronary artery disease? Who refers the patient for exercise, echocardiography, or SPECT? Okay, who refers the patient for dobutamine stress echocardiography? Who refers the patient for coronary CT angiography? Okay. And who refers for CT perfusion, for example? And for invasive coronary angiography? Most of you. Very good. So in this case, again, high likelihood of having coronary artery disease, so we would select a test for ischemia. And again, the same algorithm. And this is the dobutamine stress echocardiography that we perform. This is at rest, low dose, peak dose, and recovery. This is the 4-chamber view. And here in the 4-chamber view with the septal and the lateral wall, I don't see many abnormalities. This is the 2-chamber view. We could say that here at the peak stress, the inferior wall seems moving less. And this is the 3-chamber view, where we can see again the posterior wall may be moving less. But sometimes the echocardiographic window is difficult, and this is why there are several studies that have shown that the use of contrast in dobutamine stress echocardiography can help to improve the sensitivity without affecting the specificity for the detection of wall motion abnormalities. And this is the quality when we add the contrast. In this case, here the septum seems also at the base that gets a little bit stuck, and the inferior wall here, not only at peak but also at baseline, it seems also that it's already hypokinetic, so we can see it much better. And this is the 3-chamber view with the anteroseptum still relatively okay, but the posterior wall really claudicating at the peak stress. And this is the coronary angiography of this patient with 3-vessel disease. She was referred for a bypass operation. So these are 3 cases and illustrating 3 different ways of using imaging techniques to assess the presence of coronary artery disease. But now the question that comes is, will the assessment of myocardial ischemia remain still crucial to recommend coronary revascularization? Because I'm sure that you all are aware of the results of the ischemia trial, where there were 5,000 patients with known anatomy of the coronary arteries based on CT coronary angiography and with moderate and severe ischemia, who were randomized to conservative treatment or revascularization. And actually, for what concerns the follow-up at 5 years in terms of cardiovascular death, myocardial infarction, hospitalization, or heart failure, there were no differences. So I'm sure that we will learn more from this trial later on. But in conclusion, I think that we have 4 imaging techniques to evaluate coronary artery disease. All of them can provide anatomical or functional information, depends on which one we use. But always each imaging technique should be used clinically driven and thinking about the needs of the patient and the characteristics of the patients that you have. Thank you very much for your attention.